Hello everyone. In our last video, we discussed about imaging of oral cancer and looked at how MRI is an excellent imaging modality to evaluate tongue cancer. In this video, we are going to see how to image lateralized tumors for oral cavity such as Buccal Mucosa, Gingiva, Gingivobuccal Sulcus and Retromolar Trigone. Before we begin, for those who are new to this channel, I am Dr. Parveen Ahlawat. I am a consultant at Rajiv Gandhi Cancer Institute and Research Center in New Delhi over 12 years. And I have been practicing and teaching oncology for more than a decade. I completed my MBBS and DMRT from CMC Vellore, did my DNB at Rajiv Gandhi Cancer Institute, pursued a fellowship at Royal Marsden Hospital in London, and I have later undergone specialized training in cyberknife from the United States. You remember that we divided the entire topic of oral cavity cancer imaging in 4 parts. In part 1 video, we discussed basics of CT and MRI for oral cancer. In part 2, we discussed about how to image tongue cancer. There, we saw how MRI is an excellent imaging modality for tongue cancer. Today, we are going to cover the 3rd and 4th part of this series in imaging for lateralized tumors such as tumor arising from buccal mucosa, upper and lower GB sulcus, gingiva, and retromolar trigone. We will also see how to deal with neck in a clinically non-palpable node and zero neck. And finally, we will see what all imaging to be done for distant metastatic workup. This is going to be a really long lecture. This lecture is not going to be a routine radiology lecture. Rather, I am going to show clinical correlations of each imaging finding. Let us start. We are moving away from the center of mouth and looking at lateralized tumor. This includes carcinoma of the buccal mucosa, upper and lower gingiva, upper and lower GB sulcus, and retromolar trigone. Listen carefully, because when we move to these lateral site, the entire surgical paradigm shifts. For the tongue, we were absolutely obsessed with soft tissue extension, depth of invasion, and a neurovascular bundle involvement. But for these lateralized tumor, the anatomy changes. Hence our question changes. These cancers sit dangerously close to the mandible and maxillary bone and the deep facial spaces. To stage cancers arising from these subsites correctly and plan your surgical resection, there are exactly 3 critical parameters you must evaluate on these scans for this cancer. Number 1, whether the bone is involved or not by the tumor. 2, posterior soft tissue extension. Specifically, how far back the tumor has reached into the masticated space and infratemporal fossa. 3rd, whether there is a perineural invasion present or not. We are going to tackle the most immediate and common clinical dilemma first. How to assess bone involvement. We need to get this right because this single parameter dictates your entire surgical plan. It is the difference between safely preserving the patient's jaw with a marginal mandibulectomy or forcing them to undergo a highly morbid segmental resection. Let us start. These are the literatures I have used for my lecture. Many of the concepts and imaging I have shown in my video are from these articles. I highly recommend that all oncologists, especially surgical oncologists, must read these articles. 2 of these articles are by Dr. Suprita Arya and the other 2 are by Dr. Abhishek Mahajan. In my previous video, we took a deep dive into basics of CT and MRI for evaluating a patient with oral cancer. I explained you in that video in detail Why do we need to ask for 3 important additional steps when ordering CT of the head and neck? I will keep this brief here. Let us look at exactly what you need to write on your radiology's request form. This is a critical habit to build right now in your residency. If you write a vague request, you will get an incomplete scan and ultimately incomplete report. You must dictate exactly what you need from your radiologist. Look at the screen. I call this a perfect request form for a CT scan of head and neck. I highly recommend you to copy this exact wording to ensure we get accurate and complete reading for your patient. First, you will ask for a contrast enhanced CT of the head and neck. Second, you must specifically mandate the puffed cheek technique. Listen to me carefully. If you do not explicitly write this on your requisition form, the technician will likely not do it. The buccal mucosa will remain opposed to the gingiva and you will miss subtle mucosal lesions. Third, you explicitly ask for a true bone algorithm. And note that this must be a separate reconstruction. It is not just adjusting the bone window on the viewing console. You need that dedicated high spatial resolution to catch early cortical erosion. Finally, you must request multi-planar reconstruction. Do not just settle for standard axial CT cuts. You specifically need the coronal and parasagittal views. Those specific planes are absolutely mandatory to accurately map and assess the exact length of bone involvement. Only when you get all these things right on your request form are you actually reading to confidently evaluate an oral malignancy. Take a picture of this slide right now, keep it in your phone and make sure you use this exact wording every single time. Henceforth in exams, do not say only CECT neck when you get a patient with lateralized tumors in bone marrow, gingiva, GB sulcus or RMT. Say this perfect way of asking CT scan. Examiners will be happy when you say this. Before I go on to discuss imaging for lateralized tumor, I want to show you the importance of looking at bone window if you are planning to do a CECT neck with an example. Look at the image on the left. This is your standard CECT with soft tissue window. You can clearly see the tumor mass in the right lower Gingivobuccal Sulcus shown by black arrow. Now look at the mandible right next to it. It looks bright white. It looks solid. It looks intact. If you stop here, you will stage this patient as T2 based on its size and tell the surgeon bone looks clear. You can probably save the mandible and do marginal mandibulectomy. But you would be wrong. Look at the exact same slice on the right side, but switch to bone window. Suddenly, that solid white block reveals its true structures. Do you see the arrow? There is a clear erosion of the cortex. The barrier is breached. Why does this single click of button matter? Because finding this erosion changes everything. First, the patient just jumped from T2 directly to T4A, and this is a massive upstaging. Second, if you had relied on left image, that is soft tissue window image, you might have planned a marginal mandibulectomy, thereby saving a major part of mandible. But this image tells you that you must sacrifice mandible by doing a segmental mandibulectomy. That is why when you are asked in exam which imaging modality will you do for a buccal alveolar RMT carcinoma and you have decided to say CT neck, do not just say CT neck. You should say CECT neck with puffed cheek and bone algorithm reconstruction. Let us move to our main topic of discussion now, imaging for lateralized tumors. Look at these three patients on the screen. On the left, you see an ulcerative lesion creeping into the retromolar trigone. It looks superficial, but remember what we said about RMT in our anatomy class. The bone right beneath the RMT, there is a bone right beneath the RMT. In the middle image, look at this large ulceroproliferative growth over the upper gingiva going onto hard palate. And on the right image, you are seeing a large fungating mass involving the hard palate and buccal gingiva. Now listen carefully. For the tongue carcinoma, we were obsessed over soft tissue extension and depth of invasion. But for these patients with lateralized tumor, the surgical question shifts now. It is no longer just about soft tissue. The clinical question now becomes, is the mandible or maxilla involved or not? This is not just an academic question. This dictates this type of surgery you will do. If there is no bone involvement, we can do a marginal mandibulectomy, thereby preserving significant part of mandible. This is a very good thing for the patient. But if there is bone invasion, we will have to do a segmental mandibulectomy. You will have to sacrifice mandible. Before we jump into radiology and start looking at some evidences, I want to pause and talk about why we care so much about bone invasion. Why do we spend so much time debating whether a scan shows bone involvement or not? Because the answer to this question has a direct and one of the biggest, most life-altering decision you will ever make for a patient. Marginal versus segmental mandibulectomy. Let us look at the diagram on the screen. If the tumor is just sitting next to the bone or maybe just nibbling the very outer cortex, we can do a marginal mandibulectomy. We shave off the involved bone, and this is the most crucial part, we preserve the inferior significant height of the mandible. See this image. We keep the structural continuity of the jaw intact. The patient wakes up, his face looks normal, and he can still chew, swallow, and speak relatively well. But if the tumor has actually invaded deep into the bone, then this option of preserving his jaw is gone. We cannot preserve his mandible now. We have to do a segmental mandibulectomy. We have to cut entirely through the jawbone, completely breaking the continuity of arch. See this image. I need you to understand that a segmental resection is not just a slightly bigger surgery. It is a massive functional and cosmetic blow to the patient. You are taking away his normal facial contour. You are drastically reducing his quality of life, his ability to eat in public, to speak clearly, and to swallow without aspirating. Not only this, it requires him to undergo a highly complex reconstruction, usually requiring a fibula-free flap, which dramatically increases the time under anesthesia, the ICU stay, and the risk of severe post-op complications. You are entirely altering the quality of life of this patient by doing segmental mandibulectomy. And that is exactly why you cannot guess if the bone is involved or not. You cannot just examine the tumor and assume the bone is involved. You need absolute, bulletproof diagnostic clarity about bone involvement before you take patient to the operation theatre. So how do we get that clarity? Which imaging modality do we actually trust to make this massive surgical decision? CT, MRI, or PET-CT? Let us look at the data and evidence, not opinions, only data. The question is, which imaging modality is best for suspected bone erosion? So this table is from Mahajan et al. 2023 guidelines on oral cancer imaging. If you haven't read this paper, please read it soon. It is the absolute gold standard for our patient from North India. Let us break down these numbers, and I want to explain exactly what they mean. First, let us look at the PET-CT. The sensitivity is 80%. Specificity is 66.6%. And diagnostic accuracy is 72.5%. Let me tell you the meaning of these numbers. In the world of diagnosing bone invasion, PET-CT is the absolute worst performer. Why? Because a PET scan lights up for any metabolic activity. It cannot differentiate between actual cancer invading the bone and simple inflammation from a bad tooth. So, for evaluating the primary site, specifically for bone involvement, throw PET-CT completely out of the window. Never tell an examiner that you would order a PET-CT to assess the primary extent of a lateralized tumor. The real fight for bone involvement is actually between MRI and CT scan. Let us compare them head to head. Look at sensitivity first. It is a tie. Both are at 88%. What does sensitivity actually mean to us? Think of it as your catch rate. It means if there is really a cancer involving a bone, both CT and MRI are equally fantastic at catching it. They will both raise their hand and say, hey, yes, something is wrong with this bone. But look at the specificity. This is where the entire game changes. The specificity of MRI is 73.3% compared to a stronger 80% for CT scan. What does specificity mean for you as an oncologist? Specificity means the scan can correctly identify inflammation and not mistake it for cancer. Because MRI is incredibly sensitive to any fluid or tissue change, it frequently overreacts. MRI often hallucinates bone invasion. If the patient has a bit of bone edema from a recent biopsy or inflammation from a bad tooth or periodontitis, the MRI might light up and flag it as cancer. This is a false alarm. It scares you into thinking the bone is destroyed when it actually is not. CT scan, on the other hand, has a high specificity. It doesn't get confused by simple inflammation. If a high quality CT scan in bone window shows there is cortical bone erosion, you can trust it. It is definitely cancer and nothing else. It doesn't give you those false alarm. And that brings us to the final column, diagnostic accuracy. Here, CT scan wins again at 90%. So what do these numbers actually mean for you in clinical practice? It means if you have a lateralized tumor like lower gingiva, buccal mucosa, lower Gingivobuccal Sulcus or RMT, and your primary question is the mandible destroyed? Your absolute best tool is a CT scan. Do not say MRI or worst PET-CT. In the previous slide, I showed you that MRI has a lower specificity for bone and that it essentially hallucinates cancer. Now, I want to show you exactly why that happens. I see MRI as a drama queen. Drama queen. Why? Let me take you through a very real, very tragic clinical cascade that happens in hospital all the time. Look at the image on your left side of your screen. Think about your average oral cancer patient. They almost always have poor dental hygiene, isn't it? They have periodontitis or maybe a dental abscess. That poor hygiene causes simple inflammation and fluid buildup, what we call reactive edema, inside the bone marrow of the mandible. Now look at the MRI, a drama queen of this patient. There is an enhancing lesion in left lower Gingivobuccal Sulcus in close contact with the entire height of adjacent mandible. Also see that the bright white glowing signal in the left mandible where the arrow is pointing. MRI is incredibly sensitive to fluid. So when it scans that inflamed jaw, it overreacts. The marrow edema glows brightly on the scan, completely mimicking cancer. Your radiologist sees that glowing marrow and writes suspicious for bone invasion. Based on this false positive report, your patient is upstaged to T4A. You read that report, you take the patient to OT and you perform a massive life-altering segmental mandibulectomy. A week later, you get the final histopathology report and you get shock. The report says reactive edema, no tumor in the bone. You just cut out a healthy segment of the patient's jaw because MRI hallucinated and lied to you. Remember, because of the drama queen effect of MRI, that enhancement in mandible shown with white arrow could just be fluid from a bad tooth next to the tumor. This is exactly why we need the truth teller, and that is your CT scan. A CT scan doesn't care about fluid. It completely ignores the edema. See here. It only looks for a hard physical evidence, a literal physical break in the hard white cortex of the bone. Because it demands this hard evidence, it gives you that high specificity we talked about. So here is your golden rule for clinic. When you are looking at a scan trying to decide if you need to sacrifice a patient's jaw, do not let the MRI panic you. Trust the CT scan. To really lock in this concept of bone invasion, let us step out of the statistics and look at three very real clinical scenarios. Very interesting cases. We are going to look at these cases of floor of mouth cancer. Why specifically the floor of mouth? Because as we discussed in our anatomy session, this area is basically a gutter. When there is a tumor in its location, it is often in close proximity to the adjacent lingual cortex of lingual surface of mandible. Suppose you examine such patient, you notice that the tumor is physically touching the bone or abutting the bone. But here is the important question. Is it just touching the bone or is it actually invading it? Do we have true diagnostic clarity? We need to answer whether the bone is involved or not because the answer dictates your entire surgical plan. If that bone is invaded, you have to perform segmental mandibulectomy. And as you guys know, that means cutting right through the jaw, destroying the bony continuity and committing the patient to a massive complex reconstruction. So as we go through these next 3 cases, I want you to keep a simple question in the back of your mind. For all 3 of these patients, we ordered both an MRI and a CT scan. Let us look at CT and MRI side by side and see which modality actually helped us in making the right surgical decision. Pay attention. This is case 1. This is a patient who presented with a carcinoma in floor of mouth on the left side. When you examine her in clinic, you can feel the tumor is directly abutting the adjacent mandible. This is how it looks on a diagram. As you can see, it is abutting mandible. But your clinical exam cannot give you the definitive answer we need. Is the tumor just pushing against that lingual cortex, or is it actively invading it? This is the critical juncture. If the bone is involved, we have to cut the jaw and perform a segmental mandibulectomy. If the bone is clear, we can get away with marginal mandibulectomy, thereby saving her mandible. Let us look at the scans to get our answer. Look at her MRI on the left side. You can see the dark tumor mass sitting right next to the jaw, mandible, where the white arrow is pointing towards. But I want you to look really closely. There is a clear plane of separation. You can see that thin black space acting as a boundary between tumor and bone. Also notice there is no abnormal signal changes in the bone marrow of the mandible. The marrow looks homogeneously bright. Now let us cross-check it with the CT scan on the right. This confirms exactly what we were looking for. Look at that bright white cortical line. It looks quite similar to the opposite side of mandible cortex. It is a nice, crisp and completely unbroken cortex. So in this case of left side floor of mouth carcinoma, both modalities, CT and MRI, agree perfectly, and they say there is no bone invasion. This is your easy case, true negative scenario. Because we had diagnostic clarity, we took this patient to operation theatre, performed a conservative marginal mandibulectomy and successfully saved her jaw. Did the surgeon get shock after 10 days and felt guilty? Why did he conserve this patient mandible? No. The final histopathology confirmed the bone was completely free of tumor. Patient is happy, surgeon is happy. We achieved a massive functional advantage for this patient simply by reading the scans correctly. This is case 2. This is a man who also presented with a carcinoma on the left side of his floor of mouth. On clinical examination, the tumor is slightly adherent to lingual cortex of mandible. The clinical question remains exactly the same. Is the bone actually involved or not? Can we safely get away with the marginal mandibulectomy, or are we forced to sacrifice the jaw by doing segmental mandibulectomy? Let us look at the imaging. Look at the MRI on the left. You can clearly see that the dark tumor signal has not only pushed up against the lingual surface of mandible, it has completely breached the cortex and replaced that bright marrow signal inside the jaw. Now look at this CT scan image on the right. Look at where the white arrow is pointing. That crisp white cortical line we saw in the previous patient CT scan is completely gone in this case. It is totally destroyed. Compare it with the healthy opposite side. The bone here looks moth-eaten here. So in this case, we again have absolute agreement between MRI and the CT scan. Both scans are telling us loudly and clearly that there is a gross invasion of mandible. This is our classic true positive scenario. Because we had this diagnostic clarity about bone involvement, the patient underwent a segmental mandibulectomy. After 10 days, when the surgeon got histopathology report in his hand, did he get shocked? Did he feel guilty? Why did he do such a massive mandibular resection and sacrifice mandible? No. The final histopathology confirmed our imaging. The mandible was indeed heavily involved by the tumor. Now, unlike the previous patient, we could not save this man's jaw. We had to sacrifice the bone, give him a discontinuity defect and cause a significant facial disfigurement. It is a harsh reality, but we absolutely did the right thing. Why? Imagine if you had looked at these scans, ignored the gross bony destruction and tried to do a conservative marginal mandibulectomy. You would have cut right through the middle of the tumor. You would have left gross residual disease behind in the marrow, and you would have almost certainly lost this patient's life within 1 year. See, imaging is not just about knowing what surgery to do. It is about knowing when a radical surgery is the only thing that will save your patient. So case 1 was easy. Case 2 was obvious. This is case 3. This is the real trap. Pay attention. This is the case that will try to trick you in your exams, and more importantly, it is the case that will keep you awake at night in the clinic. So we have this young patient with a carcinoma of the anterior floor of mouth. See here. And this is how it looks on diagram. As you can see, it is abutting central arch of lingual surface of mandible. The clinical question is again the same. Is the bone involved or is it just an abutment? Essentially, we want to know should we just shave the bone or do we cut it? Do we do a marginal mandibulectomy or a segmental mandibulectomy? Look at the MRI on the left. This is a lesion in the anterior. There is a lesion in the anterior floor of mouth. See where the arrow is pointing. Look at that cortex. It looks completely blurred. That distinct protective black line we saw in our first patient's MRI is gone in this patient. That black line is broken here. The tumor signal seems to be merging directly into the bone. If you look at the radiology report for this MRI scan, it says suspicious for cortical invasion. Suspicious for cortical invasion. Now look at the CT scan of this patient. Look closely at the bone window. Is that white line broken? No. It is not broken. It is perfectly smooth. It is completely intact. So here in this third case, there is a major disagreement between MRI and CT scan. How? The expensive modern MRI scan is screaming, the bone is invaded. Go ahead and do segmental mandibulectomy. But the basic CT scan is saying, relax, it's fine. Don't do segmental mandibulectomy, just do marginal mandibulectomy and save mandible. Who do you trust? The answer lies in that evidence table I showed you 5 minutes ago. The sensitivity of picking up bone involvement is similar for both MRI and CT scan. But CT has a higher specificity. So whenever you are in doubt about bone invasion, who will you trust? You trust the CT scan. So this patient was taken to operation theatre. We trusted the CT scan, performed a marginal mandibulectomy and saved his jaw. Did surgeon get a shock when he got the histopathology report in his hand after 10 days? Did he regret doing a marginal mandibulectomy? Did he compromise on his outcome by not sacrificing mandible and saving the patient's mandible? No. The final histopathology came out to be absolutely negative for bone invasion. The MRI was lying to us. Why? Because as we discussed, the MRI often hallucinates. In this specific case, that blurring you saw on the MRI was not cancer at all. It was a false positive effect caused by a chemical shift artifact and local dental inflammation. Here is your major clinical takeaway. When MRI is acting like a drama queen, showing blurring, edema and panic, but the CT cortex is solid and intact, you trust the CT scan. Mind you, if you had just blindly listened to the fancy and costly MRI, we would have cut out this young man's entire anterior mandible. He would have woken up with a massive, life-altering facial disfigurement for absolutely no reason. Do not fall into the MRI trap when you are making surgical decision about the bone. I hope with these 3 patients as an examples, you are clear that for lateralized tumors, you should say CT scan in exam, not MRI, not PET-CT. Okay, so we have spent quite a lot of time learning how to use a CT scan to definitely prove whether or not the bone is involved. But here is the hard truth. Just knowing that the bone is involved is not enough. You cannot just look at a scan, see a cortical break, write T4A in the patient's file and call it a day. If you do that, you are walking into the operation theatre room completely blind. Listen, once your CT confirms that the tumor has invaded the mandible, you must immediately answer these 3 important surgical questions. Number 1, which segment of mandible is involved? Is it the middle third segment? Lateral segment? Number 2, what is the exact length of erosion? How much bone actually needs to be resected? Number 3, what is the depth of involvement? Is it just the cortex alone, or has the tumor plunged deep into the marrow and the inferior alveolar canal as well? The answer to these 3 specific questions dictate exactly where your scalpel is going to go. They dictate whether you are doing a relatively straightforward resection or if you need a massive, complex fibula-free flap to rebuild the patient's face. But we are not going to answer these questions today. Figuring out exactly how to map this dimension on a CT scan, how to plan your bony margin and how to execute the perfect mandibular cut is another topic on its own. So I am going to cover the exact answer to these 3 questions along with our complete surgical algorithm in a separate dedicated lecture specifically on mandibular management. If you want to know how we take this radiology and turn it into actual life-saving surgery, make sure you tune into that next video. Okay, listen now. We have spent enough time on the first parameter, bone involvement. By now, you guys know exactly when to cut the jaw and when to save it. You know that CT is your best imaging modality when it comes to see bone involvement. Let us move on and look at the second parameter we need to assess for lateralized tumor. It is perineural invasion. Perineural invasion, PNI. Now for lateralized tumors such as Buccal Mucosa, upper and lower gingiva, upper and lower Gingivobuccal Sulcus, Retromolar Trigone, This is where the real game begins. See, bone dissection was obvious. It is loud. You can see the cortex getting eaten away by the tumor. But perineural spread? It is absolutely silent. What happens is the tumor cells latch onto a nerve and they just use it like a highway to travel far away from the primary tumor, sometimes going straight up to the skull base. If you don't pick perineural invasion on your pre-op imaging, what happens? I'll tell you what happens. You will do your resection. Your gross margins on surgical table looks perfectly fine. You come out of OT very happy. 6 months later, the patient will come back to your OPD with a massive undissectable skull base recurrence. Why? Because you unknowingly left microscopic disease behind in that nerve canal. See, you cannot see these nerves with your naked eyes in the OT. You have to catch this perineural invasion on the pre-op scan before you even touch with the knife. So how exactly do we track down these hidden nerve pathways on our scans? Which sequence do we order? Let us look at that in detail. Suppose a patient with lateralized tumor comes to your OPD and says he feels formications, meaning ants crawling on his cheek. We call it numbness or paresthesia. Now we have to figure out if a nerve is involved by his tumor to explain these symptoms. So the critical question becomes, which imaging do you want to do for this patient to look for perineural invasion? CT or MRI? Look at the table on your screen. Once again, this is straight from Mahajan et al. 2023 guidelines. This table shows a comparison of sensitivity and specificity for perineural invasion between CT and MRI for oral cancer. I really want to spend some time on this table to explain you these numbers. This is a clinically very important issue you will face in your practice. So pay attention, please. I want you to focus right here on the sensitivity column. MRI has a perfect 100% sensitivity. What does this 100% sensitivity of MRI mean to us oncologists? It means the MRI scan will successfully identify absolutely every single case having perineural invasion. In clinical and statistical terms, a 100% sensitivity translates to having virtually zero false negative. Zero false negative. If the cancer has involved a nerve, the MRI will simply not miss it. For you as a surgeon, this means you can trust an MRI scan completely. If a high quality MRI confirms there is no spread detected along the nerve, you can safely proceed with a conservative functional preserving surgery such as marginal mandibulectomy without the fear of leaving microscopic disease behind. But there is a trap here with MRI. Look at the specificity of MRI to pick up perineural invasion. It is 85%. What does it mean to you as a surgeon? Let us break down the math. An 85% specificity means that out of 100 patients who absolutely do not have perineural invasion, the MRI will correctly report as clean normal scan in 85 of them. But what about the other 15? that 15% is your false positive rates. False positive. That means in 15 out of 100 healthy nerves, the MRI will light up, show enhancement and falsely tell you there is a tumor spread in the nerve when there is absolutely no cancer there. Why does the MRI lie to us 15% of time? Because MRI is incredibly sensitive to water and blood flow. When the blood-nerve barrier breaks down for any reason, IV contrast leaks in and the nerve enhances. So MRI overestimates perineural invasion in 15% of cases. Which are those situations where MRI overestimates PNI? If your patient has severe periodontal disease, a bad tooth, dental infections, or if you just did a deep punch biopsy in the OPD a few days ago, that local inflammation will cause the nerve to enhance brightly on the MRI. To the untrained eye or inexperienced eye, this inflammatory enhancement looks exactly like aggressive perineural tumor spread and you report it as likely PNI present. Here is a clinical trap. If you do not understand that 15% false positive rate, you will look at that brightly enhancing nerve, get panic and drastically changes your surgical plan. You will subject that patient to a massive segmental mandibulectomy, needlessly cutting out a huge block of bone when all they really had was a bad tooth or a biopsy inflammation. So write this golden rule down for your clinical practice. A negative MRI definitely rules out nerve spread. If MRI says nerve is not involved, believe it 100% of the time. If MRI says nerve is not involved, believe it 100% of the time. You can trust it. You take your treatment decision considering no PNI without any fear. But when MRI says perineural spread is present, stop and think. Correlate MRI findings with your clinical examination. Go back to the patient and take history and do physical examination again. Does the patient actually have numbness? Are their teeth infected? Never blindly sacrifice a patient's jaw or label them incurable just because an MRI showed enhancement. You have to be smarter than the scan. Alright, let us look at numbers for CT scan regarding PNI. CT scan has a sensitivity of 88% and a specificity of 89%. What does these numbers actually mean for you when you are going to decide a patient's fate? Let us break down the 88% sensitivity first. This means out of 100 patients who actually have their cancer spread to nerves, the CT scan will successfully spot it in 88 of them. But it completely misses the other 12. That means you have a 12% false negative rate. Now some of you might look at that and think, sir, 88%, that not so bad. Let me tell you, in oncology, 88% is a complete disaster. It means that statistically, if you rely on a CT scan, you are going to miss 1 out of every 8 cases of nerve spread. That is one patient in an OPD who is going to undergo less conservative surgery because your CT scan said clean scan for PNI and will come back 6 months later with a massive inoperable skull-base recurrence. Think about it. Why was CT blind there? Why is the CT missing PNI 1 out of every 8 cases? Because CT scan relies on indirect signs of PNI, which occurs late. Indirect signs which occur late. What does it mean? See, you can see bone invasion well and early on CT scan. But you cannot see direct nerves on CT often because CT has a poor soft tissue resolution. If the tumor is just a microscopic cluster of cells silently creeping along the nerve, the bone has not changed yet, and your CT scan will look perfectly normal even though the perineural invasion has started to develop. For a CT scan to definitely show perineural invasion, the tumor has to grow large enough to physically widen or erode the bony canal, such as the infraorbital canal, inferior alveolar canal, mandibular canal, greater palatine foramen, or foramen ovale. This widening or eroding the bony canal findings takes time to develop, much later than the actual perineural spread has started. So by the time you see these late indirect signs of PNI in CT scan, the cancer is already massive and advanced. Now let us look at the specificity of CT scan for PNI. It is 89%. What does it mean? This means in 100 patients without nerve spread, the CT scan will correctly call 89 of them as having no PNI. But in 11 patients, it will falsely raise an alarm and will report as PNI present. That is 11% false positive rate. Why do you get 11% false positive rate? Because if you are only looking at bone windows in CT scan, you are forced into a dangerous guessing game. You are constantly looking back and forth, comparing one bony foramen against the contralateral side, trying to detect slight asymmetries. A slight anatomical variation or benign bone remodeling can easily trick you into thinking a foramen is widened by cancer, when it is actually not. This brings us to the ultimate verdict. Why is MRI the absolute, undisputed gold standard for perineural invasion? It all comes down to visualizing the soft tissue. MRI is direct and it is early. You do not have to wait months for the bone to get destroyed. When cancer cells invade a nerve, they disrupt the blood-nerve barrier. This causes contrast of the MRI to leak in, which shows up on an MRI as bright, abnormal nerve enhancement long before the nerve even physically enlarges or touches the bone. A T1 post-contrast fat-saturated MRI explicitly suppresses the bright signal of normal fat, making these enhancing tumor tissues light up like a beacon inside large spaces like the pterygopalatine fossa. Because MRI offers incredible superior soft tissue resolution over CT, it catches the disease exactly when it matters, early. MRI relies on direct signs of nerve involvement. It sees the direct nerve itself. It sees the enhancement. It sees the thickening long before the bone is ever picked up. It spots the invasion of nerve while it is still quietly traveling inside the foramen. So burn this rule into your mind. A standard CT scan is completely inefficient for ruling out early perineural spread. So here is the clinical trap I want all of you to avoid. Imagine a patient comes to you and says, "Doctor, I feel ants crawling on my chin, or my cheek feels heavy." You order a CT scan. The radiologist report comes back skull base normal, foramen intact. Do not believe it. The symptoms of this patient are real. The CT is just not sensitive. If you have clinical suspicion, numbness, tingling, pain, a normal CT scan means absolutely nothing. You must order a contrast MRI. As this table proves, it is the only way to be 100% sure you are not leaving cancer behind. I hope you understand the evidence behind why we choose MRI to detect perineural invasion. So explain this in exams to your examiner. Alright, so now you know exactly what to look for on the MRI. But the next logical question you must ask yourself is, where exactly are we looking? In our clinical practice of oral oncology, there are three major pathways of perineural spread we usually see for oral cancer. A tumor loves to travel along these nerve pathways. Before we zoom in and dissect the intricate radiological anatomy of each individual pathway, I need you to understand the big picture. Look at this slide on your screen. This is your ultimate clinical cheat sheet for OPD. It beautifully maps out the three major pathways of perineural spread, directly linking the primary tumor site to its specific high-risk neurovascular escape route. I want you to burn these three scenarios into your memory, because your clinical suspicion has to start the moment you examine the patient, long before the patient ever enters the MRI scan. Let us go through them. Look at the first scenario at the top. If you are examining a tumor sitting on the lower gingiva and your patient complains of an indicator symptoms like numbness in their lower lip, chin, your brain must immediately fire a red alert. You must instantly suspect inferior alveolar nerve perineural invasion. Now move to second scenario. Suppose you have an upper jaw carcinoma. If a patient with tumor in the upper jaw region says he feels numbness over his malar region like crawling sensation on their cheek, you are no longer just dealing with a simple mucosal lesion. You must highly suspect infraorbital nerve involvement. If the patient with tumor in his hard palate says symptoms and signs suggestive of nerve involvement, look for the involvement of greater palatine foramen. These are the three major highways that oral cancer hijack. You cannot image what you do not suspect, and you cannot treat what you do not see. So keep this mind clearly in your mind. Now that we know which nerve to suspect based on the tumor site, let us take them one by one and learn exactly how to track them on the scans, starting with our first highway, the inferior alveolar nerve. Inferior alveolar nerve. So let us start with the lower jaw tumor. Let us trace the path of inferior alveolar nerve. Let us start with the mandibular region tumor and deal with one of the most critical and challenging aspects of oral cavity imaging, visualizing the invisible. I am talking about the picking up inferior alveolar nerve involvement. Imagine a patient with a tumor in the lower gingiva sitting in your OPD. If he tells you that he has numbness, tingling, or an altered sensation over his chin, you must immediately suspect potential perineural invasion of inferior alveolar nerve. Remember, this nerve runs directly inside the mandible. As we discussed earlier, tumors in lower gingiva, specifically on lingual surface of gingiva, lower Gingivobuccal sulcus and buccal mucosa, sit dangerously close to the bone. The absolute biggest threat here is perineural invasion of inferior alveolar nerve. This is where the carcinoma sneaks into the nerve and travels deep inside the bone, completely hidden without showing you any surface sign. You simply cannot see this with your naked eye in the clinic. If you just blindly rely on a standard CT scan here, it will only pick up nerve involvement at a much later stage. It waits until there is an actual physical widening or erosion of mandibular canal. This is exactly why we need MRI. We use it to map out this hidden pathway right from the start, taking us all the way from ruling out early microscopic spread to accurately defining our actual surgical margin. So why does all this meticulous radiological details actually matter to us in clinic? Why should we care so much about the inferior alveolar nerve? Because it strictly dictates your surgical plan. Take a look at the anatomical path on your screen. This is your danger zone. It runs from the mental foramen straight through the mandibular canal all the way back up to the trigeminal ganglion. If your high quality MRI confirms there is no spread detected along the nerve, you can safely plan a marginal mandibulectomy. This gives a massive functional advantage for your patient because you preserve the functional continuity of the jaw. However, if nerve involvement is confirmed, your entire surgical plan changes. You can no longer preserve the mandible. You must do a segmental resection. You have to remove the full width of jaw to ensure you clear the disease, and as you know, this major bone resection severely drops the patient's quality of life. But here is where I need you to pay attention. I am going to leave you with a very crucial clinical trap. We know the sensitivity of MRI for this is phenomenal. It is up to 100%. If perineural spread is present in that canal, the MRI will simply not miss it. There are virtually zero false negative, but you must be beware of the mimic. Simple inflammatory changes like bad tooth, adjacent dental disease, periodontitis, or even a recent biopsy can also enhance brightly on an MRI. They closely mimic actual tumor extension. So you have to correlate clinically and differentiate these carefully. If you don't, you risk severely over-treating your patients, cutting out a massive segment of jaw that didn't actually need to be removed. Alright, let us look at a real-world case that perfectly explains why you have to be absolutely paranoid about perineural invasion. This patient has a carcinoma in left buccal mucosa, posteriorly going into retromolar trigone. We are looking at the T1 weighted post-contrast MRI of this patient. Now you might think a buccal cancer is just a superficial cheek problem. But remember your 3D anatomy. It can easily access the retromolar area and the masticated space. And once it is there, the major nerves are completely exposed. Look at image A on far left. That yellow arrow is pointing directly to the left inferior alveolar canal. Notice how thick and brightly enhancing it is. This is not normal. You can compare it with opposite side. You see nothing in the opposite side. The tumor has infiltrated the inferior alveolar nerve and is actively using it as a pathway, crawling retrogradely, moving completely away from its epicenter. Now skip to image C on the far right. This is a coronal view. We are tracking that exact same nerve, the mandibular branch of the trigeminal nerve or V3, all the way up to the base of skull. Look at that yellow arrow. It is showing you gross enlargement and direct tumor involvement right at the foramen ovale. Finding this instantly upstages your patient to a T4B. It renders the disease entirely unresectable. But here is where the biology of perineural spread gets incredibly dangerous. Look at the middle scan, image B. Nerves do not exist in isolation. They have communicating branches. Because this tumor marched all the way up to the skull base, it is actually jumped pathways. The yellow arrows in this axial cut are showing you abnormal enhancement of facial nerve. And look at the red arrow. That is greater superficial petrosal nerve lighting up. The cancer has spread through an entire network of interconnected cranial nerves deep inside the skull. Think about this for a second. If you had only relied on physical examination of the cheek, or if you had just ordered a standard CT scan, you would have completely missed this massive perineural spread. You would have taken this patient to the OT, you would have been very happy performing a fantastic surgery, only to have the margins come back positive on the final histopathology report. This is the worst thing that can happen to a patient. And this is exactly why we strictly mandate high quality MRI. We must map out these hidden pathways before we even touch patient with scalpel. Now let us move to the upper jaw tumor and talk about the next major nerve involvement, infraorbital nerve. Listen, when we deal with oral cancer, we often get so completely focused on the primary tumor inside the mouth that we completely miss the back door. I call this the silent escape route. A tumor can look completely controlled on the surface while quietly marching its way right up to the brain. If you don't actively look for this on your scans, you will miss it. And ultimately, your oversight will cost the patient his life. Look closely at the anatomical trajectory on this slide. The infraorbital nerve is a classic, highly critical pathway for perineural spread. Notice the direction of that arrow. This spread is completely retrograde. It crawls backward along the nerve, moving away from the oral cavity and heading directly towards the skull base. Listen to me very carefully. If you miss this spread anywhere during your initial staging, the clinical outcome is entirely predictable and frankly, it is lethal. So who is actually at risk for infraorbital nerve involvement? You don't really need to worry about this nerve for a tongue carcinoma or a floor of mouth cancer or even a lower jaw cancer. This specific involvement of nerve is extremely rare in these lower subsites. Instead, I want you to be highly suspicious every time you see a tumor originating in the upper anatomical tier of oral cavity. I am talking about the superior GB sulcus, the maxillary alveolus, gingiva, or hard palate. Tumors in these specific subsite easily access this nerve either through direct superior extension or through microscopic perineural invasion right into the local nerve endings. Here is the most important clinical tip I can give you today. Do not wait for the imaging to suspect this. Your diagnosis starts right in the clinic when you are taking history. Ask your patient specifically about the V2 sensory distribution. V2 sensory distribution. Are they feeling formication? They might describe this to you as a sensation of insects crawling on their cheek. Do they have paresthesia or frank numbness over the affected cheek, the lateral part of nose or their upper teeth? And here is a critical distinction to make during your physical examination. Their trigeminal motor function will remain completely intact. Why? Because the muscles of mastication are supplied by motor fibers that run exclusively with V3 branch, not V2. Simply put, if your patient can chew normally, but their cheek is numb, the infraorbital nerve is involved. Alright, so once your clinical suspicion is triggered in the OPD, once that patient tells you their cheek is numb, what is your next step? You need to visualize the entire path of this nerve spread. Look at the flow chart on your screen. I want you to think of the course of infraorbital nerve like a hidden highway. As a surgeon reading the scan, you need to check specific toll booths along this route to see exactly how far the tumor has traveled. The journey starts right here at the entry point, the infraorbital foramen, sitting right in front of the maxilla. From there, the tumor doesn't grow outward, it travels backward. It transits straight through the infraorbital canal, creeping right along the floor of the orbit. If it makes it through the canal, it hits a critical junction, the pterygopalatine fossa or the PPF. This is a major crossroads deep inside the face. And if the disease is not caught there, it reaches its final deadly destination, skull base. The tumor marches backward along the main trunk of V2 nerve, passing through the foramen rotundum and ultimately plunging directly into the cavernous sinus and Meckel's cave. What is the ultimate result if the cancer reaches this final toll booth? It becomes a T4B. And the result is certain death of your patient due to massive local progression. So how do we actually spot the tumor at each of these toll booths on MRI before it is too late? Let us break them down one by one, starting with checkpoint 1. When you sit down with your radiologist, I want you to actively interrogate 3 specific checkpoints. Checkpoint number 1 is the entry. This includes infraorbital foramen and infraorbital canal. You are explicitly looking here to check for any abnormal asymmetric enhancement or nerve thickening inside the canal. Always compare it to the normal healthy side. Look at the MRI images on the screen. In the first image, the red arrows show you clear abnormal infraorbital nerve enhancement right at the entry point. In the subsequent images, you can actually see that abnormal enhancement actively traveling backward, deep through the infraorbital canal, along the floor of orbit. The cancer is actively using this canal as a hidden pathway to migrate away from their face. Next, I want you to trace that nerve further back to checkpoint 2, the junction. We call this pterygopalatine fossa or PPF. These 2 images are hypothetical images to show you that checkpoint. Look at the normal image on the left. Because we are using a fat saturated MRI sequence, this fossa should look exactly like a dark empty box. Why? Because the PPF is naturally packed with fat and our scan suppresses that fat signal. Now look at the abnormal scan on the right. That normal dark signal is completely gone. It is entirely replaced by a bright enhancing tumor tissue. So remember this rule. If you look at the PPF and see that loss of normal fat signal, you are looking at macroscopic perineural spread right in front of your eyes. Finally, you have to trace this hidden pathway all the way back to our last stop, checkpoint 3, skull base. You need to follow the main trunk of V2 nerve right up to the foramen rotundum and the cavernous sinus. What are you looking for here? Look for any asymmetric widening of foramen when you compare it to the normal side. Crucially, check to see if there is any abnormal enhancement extending backward into the Meckel's cave. If the disease has reached this deep space, this surgical game is over. Now we are dealing with a T4B completely unresectable disease. You cannot operate on this patient, and the patient is at a very high risk of massive treatment failure. Let us pull up this all together into a rapid diagnostic algorithm for your daily practice. Step 1. Identify the risk. Is it an upper oral cavity tumor? If yes, go for step 2. Check for symptoms. Do they have a numbness in the cheek with intact motor function? If yes, step 3. Order the right test, MRI, which is a T1 post-contrast fat-sat MRI. Step 4. Interrogate. Scan yourself. Look at the canal for thickening. PPF for fat replacement, and rotundum for widening. So canal for thickening, PPF for fat replacement, and rotundum for widening. Remember, this nerve is a highway. It is your job to track the exit routes before you ever take the patient to operating room. Now, how do we actually image this hidden highway? If you just order a standard contrast CT, you are going to completely miss the early spread. A standard CT only detects late stage macroscopic bony destruction like the erosive widening of bony canal. This is completely insufficient for our clinical needs. The absolute mandate here is an MRI, specifically T1 post-contrast fat saturated MRI. Why? Because normal nerves are naturally surrounded by fat. By suppressing that bright fat signal on the scan, any enhancing soft tissue tumor replacing the nerve will light up like a beacon against the dark background. Alright, let us look at the third classic pathway of perineural invasion common in oral cancer. We just talked about the upper jaw tumor, but what if the tumor sits right on the hard palate? For a hard palate carcinoma, its absolute favorite escape route is straight up into the greater palatine foramen. I want you to look closely at this slide and compare CT and MRI. This patient has carcinoma over his hard palate, over left half and extending into left upper gingiva. Look at the axial CT on the far left side. If you look carefully at that black arrow, you might notice the left greater palatine foramen is slightly widened compared to the right side. Look in this lower images also. But now look at the MRI right next to it. The T2 weighted MRI isn't just showing you a widened bony hole, it is showing you the actual hyper intense tumor mass itself sitting right inside that space. And look at the image on the far right. When we add contrast to a coronal view, the enhancement of that mass is absolutely striking. With the CT, you are just inferring the tumor might be there, but the MRI, you are staring right at the tumor. Now let us break down why these massive differences exist. This is a fundamental concept you must grasp for your clinical practice. The difference between an indirect sign and a direct sign. CT scan only gives you the indirect sign. It can only identify bone remodeling. Think about the biology. For a bony foramen to actually look enlarged on a CT scan, the tumor has to grow large, put physical pressure on the surrounding bone, and slowly remodel it over time. This is a lagging indicator. By the time you finally see that bony changes on CT scan, the disease has been sitting there growing for quite a while. MRI, on the other hand, gives you the direct sign. Look at the image on the right. We are not waiting for the bone to change. We are directly visualizing soft tissue of the tumor itself. The T2 MRI shows that hyperintense mass actively infiltrating foramen. You do not have to wait for bone destruction to know the cancer is there. This is an important concept you should understand. And this brings us to the dangerous clinical trap we fall into if we only order CT scan. Look at these two coronal cuts. If you only have a bone window CT like the image on your left, you are basically forced to play a guessing game. You have to constantly look back and forth, comparing the affected side against the normal contralateral canal, just hoping to detect a slight asymmetry. You are entirely reliant on the bone expanding. But look at the MRI on the right. There is absolutely no guessing game here. Because of that striking enhancement, the tumor mass is depicted definitely. The MRI picks up the nerve thickening and the tumor spread incredibly early, long before the bone even starts to expand or get damaged. This early detection is exactly what prevents you from leaving disease behind in the OT. Let me show you another example showing the clear advantage of MRI over CT scan. Imagine this patient is sitting in an OPD, complaining of numbness over his cheek or chin. Now look at his CT scan on the left. It shows absolutely no enlargement of mandibular foramen. It looks completely normal. Why? Because the CT relies entirely on indirect sign and the bone has not expanded yet. So your CT scan gives you a false negative report. But now look at the MRI for the exact same patient on the right side. Because the MRI picks up direct sign, you can clearly see the nerve enhancement and enlargement. The MRI gives you the true positive picture. So here is the clinical trap I want every single one of you to avoid. A patient comes to you with numbness, tingling or pain, and they hand you their outside CT scan report that reads skull base normal, foramen intact. Skull base normal, foramen intact. Do not believe it. The patient's symptoms are real. The CT is just blind. A normal CT means nothing when clinical suspicion is high. You must order a contrast MRI. As we saw in the data, it is the only way to be 100% sure you are not missing cancer. Alright, so here is your final clinical verdict. I want you to burn this into your memory and recall it every single time you evaluate a patient for nerve involvement. Look at the comparison on your screen. CT depends on indirect signs of perineural invasion and it is late. Yes, a CT scan is fantastic if you want to look at gross bony architecture, but it is completely insensitive to early perineural spread. MRI is direct and it is early. It is the absolute gold standard for tracking perineural spread because you are not waiting for bone to remodel. You are looking directly at nerve thickening and abnormal enhancement. Here is the bottom line. If you have a case where you suspect perineural spread, like those hard palate, upper gingiva, a negative CT scan means absolutely nothing. It is simply not conclusive. An MRI is strictly mandatory to rule out nerve involvement long before the bone erosion ever happens. Never ever clear a patient for surgery based on a negative CT. Get the MRI. Let us bring it all together with the final slide on perineural invasion. This perfectly maps out what I call the hidden pathways based on the Mahajan 23 imaging guidelines. We spend so much time obsessing over the primary mucosal tumor, but you have to understand that these normal bony canals and foramen act as a direct high-speed conduit for perineural spread. If you don't actively trace these highways on your multi-planar scan, you are going to miss advanced disease. Let us start from the bottom up. For a lower gingivobuccal cancer, the primary escape route is the mandibular nerve. Look at image D on the bottom right. That green arrow is the inferior alveolar canal, the main tunnel running right through the mandible. Follow that tunnel backward to image C, where the black arrow shows the mandibular foramen, the exact entry point into the jaw. But the disease doesn't stop there. Follow it up to image A on top left. That white arrow point to the foramen ovale. This is the ultimate gateway for V3 to reach the intracranial space. You must specifically check if this foramen is widened and if the normal fat pads are obliterated. Now what if the tumor is higher up, like the hard palate? It takes a different highway using the V2 nerve. Look at image B on top right. This is your V2 junction box. The blue arrow in the foramen rotundum and red arrow in the Vidian canal. These conduits allow the tumor to spread directly into the pterygopalatine fossa and eventually skull base. I want you to burn these 4 anatomical checkpoints into your memory. Why? Because if you detect spread into these skull base zones, you instantly upstage that patient to T4B. The disease becomes unresectable. If you don't interrogate these foramen, you will take a T4B patient to operating room for a surgery that is completely futile, leaving gross disease behind in the skull base. So here is the rule. Trace the tunnel, check the foramen, and close the escape routes before you ever plan your surgery. Let me pause for a moment because I really need you to understand the absolute gravity of this. I do not want you to just memorize imaging checkpoints to pass an exam. I want you to understand exactly what happens to a patient who has perineural spread. This is not some hypothetical textbook scenario. If you ask any of us who deal with large volume of oral cancer, we will tell you that this is a very real, very tragic cascade of events. Let me walk you through the exact timeline of what goes wrong. The trigger. It all starts right in your OPD with the mere symptoms. A patient with an upper Gingivobuccal sulcus or a hard palate tumor sits in front of you. He casually mentions that his cheek feels numb, or maybe he describes a crawling sensation, formication right under his eyes. But you look at the primary tumor and it looks perfectly resectable. Their jaw movements are fine because their V3 nerve function is completely intact. So you dismiss the symptoms. You order a standard contrast CT scan which completely misses the early soft tissue spread hiding inside the nerve canal. Because you missed it on the imaging, you now plan the wrong, inadequate surgery. You take the patient to the operation theatre and perform what you think is a beautiful oncological sound wide excision or partial maxillectomy. You reconstruct the defect, the patient looks great, and you pat yourself on the back thinking you have cured this patient. But here is the hard reality. You did not track the nerve up the infraorbital canal, and you did not chase it up to the pterygopalatine fossa. A week later, final pathology report comes back, and there it is. Microscopic positive margin. Microscopic margins positive. The pathologist sees tumor cells sitting right at the cut edge of nerve bundle. You just left cancer behind. And as we all know, positive surgical margins are strongly associated with local recurrence and a poor prognosis. Now you have a massive problem. In fact, you are guilty. Anyways, you try to salvage the situation with adjuvant chemoradiation. But remember, this tumor is already in the silent escape route. It continues to crawl retrogradely, completely hidden from view, right through the infraorbital canal into the PPF and eventually through the foramen rotundum. 1 year later, the patient comes back to your clinic. This time he has come with headache and cranial nerve deficits. He is now found to have a massive skull base recurrence. The tumor has breached the cavernous sinus and Meckel's cave. At this point, your surgical options are absolute zero. The disease is now upstage to T4B. It is unresectable and essentially incurable. And the final outcome of that cascade is death. A highly predictable, entirely lethal outcome. Why did it happen? Not because the primary tumor was inherently incurable. It happened simply because you did not listen to the numb cheek. You did not order the right scan, MRI. You ordered a CT scan and hence you missed the perineural spread before you ever made your first incision. Do not let this happen to your patient. Do an MRI. Read the T1 post-contrast fat SAT sequence and track the nerve. Do not let this happen to your patients. Leave no stone unturned to rule out perineural spread before you even start thinking about admitting him for surgery. I am going to tell you some golden rules now for oral cancer imaging algorithm. Please pay attention. This is the slide you need to photograph. If you forget everything else I said today, just remember this table. Let us simplify oral cancer imaging into 4 simple rules. Rule number 1. If the tumor is in the tongue or floor of mouth, your choice of imaging is MRI neck with IV contrast. Rule number 2. If the tumor is in the lateral portion of oral cavity, for example, Buccal Mucosa, Gingiva, RMT, GB sulcus, your choice of imaging should be CECT neck with puffed cheek, with bone window and multiplanar reconstruction. Once again, it is extremely important to ask for a detailed CT scan. Trust me, the examiner will get impressed if you say this complete name of the CT scan. If you don't ask for a puffed cheek, the radiologist won't do it and you will miss the lesion. Rule number 3. If you suspect bony erosion, the imaging of choice is CECT neck, again with puffed cheek and bone algorithm and multiplanar reconstruction. Rule number 4. If your patient shows signs of any neuropathy or you suspect perineural invasion, your imaging of choice should be MRI. It is the only scan that can see the nerve before the bone widens. So, next time you are sitting in the OPD, don't guess. Look at the site and see what you are suspecting and order the right scan. Now listen very carefully, guys. This is vital for your exams. See, what I have taught you over last 1 hour is from an ideal world practice. But we live in a real world, not ideal world. MRI is a difficult test to get in many government hospitals. Its cost is almost double to that of CT scan. So practically, many oncologists end up doing a CT scan even when they need MRI. So here is my advice for the resident on Viva. If you get a tongue cancer case and you say, I would like to do MRI, and your examiner gets upset and asks, why not CT scan? Do not argue. Do not defend strongly. Answer, yes sir, ideally I want an MRI, but CECT is also a valid option if there are logistics or financial issues. It will still give us good information, though MRI is superior for soft tissue. Similarly, if you have a Gingivobuccal Sulcus case where you suspect bone erosion and you say, I want to do CT scan, and the examiner gets irritated and asks, will you be able to see the soft tissue spread? Again, don't argue. Answer, yes sir, MRI is definitely better for soft tissue, but since my main concern here is the mandible, I prefer the CT scan because it is superior for detecting cortical erosion. The point is, stick to your logic, but be practical. Clear? Alright everyone, listen up. We have thoroughly discussed how to image the primary tumor. We know now how to check for the bone and we know how to trace the nerves. But as any good oncologist knows, the primary tumor is only half the battle. The single most important prognostic factor in oral cancer that dictates your patient's survival is cervical nodal metastasis. So let us shift our focus to neck, specifically the clinically negative or N0 neck. Let us talk about a situation you all face daily in the OPD. You have a patient sitting in front of you with an oral cavity primary. You examine him, you carefully palpate the neck and you feel absolutely nothing. So you write in your notes clinically N0 neck. But you and I both know that our fingers are notoriously unreliable. The literature consistently proves that even when you feel nothing, there is an occult metastasis rate of at least 30%. Because physical examination is so blind, cross-sectional imaging of the neck is absolutely mandatory. That means we have to do an imaging to look for occult nodes. And this is exactly where I see resident making a fundamental everyday error. You rightly order a contrast-enhanced CT or an MRI to evaluate the primary tumor, to check the size, depth of invasion, bone involvement, nerve involvement. But then clinical anxiety creeps in you. Clinical anxiety. You start thinking, maybe I should get a dedicated ultrasound of the neck just for the node. Or, you know what, let us just get an upfront PET CT to be done to be absolutely sure. I'm telling you right now, stop doing this. Ordering multiple scans to detect occult node is a massive waste of resources. It delays definitive treatment and frankly, it is scientifically unjustified. Now you might ask me, sir, doesn't a dedicated ultrasound or a high-tech PET CT scan actually perform better at finding those hidden nodes? Let us look at the evidence for this. We are going to look at a very famous systematic meta-analysis by Leo et al. Published in BMC Cancer in 2012. They looked specifically at clinically N0 head and neck cancer patients and compared the true diagnostic accuracy of CT, MRI, PET and ultrasound head to head. Look closely at this data table from the meta-analysis. Look at the sensitivity column. CT is at 52%. MRI is 65%, ultrasound is 66% and the PET is 66%. What does this tell you? It tells you that sensitivity across all imaging modalities is essentially comparable and none of them are magical. They all miss microscopic disease. But now look at the specificity column. CT demonstrates the high specificity at 93%. This means if a CT scan says a node is malignant, it is highly accurate at ruling in that metastasis without giving you false alarm. So let us pass a final verdict on PET CT scan and ultrasound for N0 neck. PET CT comes with a massive cost. And as we just saw, it offers absolutely no superior sensitivity over a standard CT or MRI for N0 neck. When do we actually use it? We reserve a PET CT for patients with a high nodal burden and when we suspect distant metastasis. What about ultrasound? Ultrasound is highly operator dependent and it completely fails to assess the primary tumor or deep retropharyngeal nodes. We reserve ultrasound strictly for targeted ultrasound guided FNAC or for routine surveillance if we are putting the patient on a watchful waiting protocol. After speaking of watchful waiting, let me show you the clinical math behind it. According to Bayesian logic, your baseline pre-test probability of occult metastasis is around 30%. If you do a high quality CT scan or MRI and it comes back negative, that post-test probability now drops significantly to 18%. Why does that number matter? Because 20% is our surgical threshold. In select low-risk patient, like an early T1, T2 lesion, dropping the risk below 20% clinically justifies a watchful waiting policy over subjecting the patient to elective neck dissection. So here is your ultimate takeaway. The optimal solution for your clinical practice. Examiner often try to trap you. They will say, okay doctor, you have nicely described the primary tumor extension on CT or MRI. Now tell me which imaging modality will you choose to check cervical node metastasis. Often resident says either CT or MRI or PET CT. Listen up. You do not need to order a separate scan for neck. You need to look at nodes from the exactly same scan you did for primary tumor. One scan equals two goals. A single high quality contrast enhanced CT or MRI comprehensively evaluates primary lesion assessment, giving you the T-stage, depth of invasion, bone erosion, while simultaneously giving you high specific regional nodal assessment. Stop over investigating neck by doing another scan. If you have already done a high quality contrast enhanced imaging modality such as CT or MRI to stage your primary oral cavity tumor, use that imaging to evaluate the neck. Do not order a separate imaging modality just to look at the node. And absolutely do not order a PET scan routinely. It is expensive. And as this meta-analysis proves, it does not give you better sensitivity or specificity. Evaluate the primary and the neck together using the same high quality cross-sectional scan. you already have in your hand. Moreover, you are anyway going to do neck dissection for clinically N0 neck. Keep that in mind. Alright, let us shift our focus from loco-regional staging to distant metastatic workup. I want you to pay attention to this slide because I see residents, even some early career oncologists, get this wrong all the time. We need to be precise and evidence-based. Let us look at the routine workup first. Where do oral cancer typically metastasize? The lungs. So you should order a standard X-ray, chest X-ray. Should you order a standard chest X-ray? No. A plain radiograph chest X-ray may pick up large lung masses but completely misses small or subpleural lesions. You must order a CT of the thorax with or without IV contrast. That is up to you. I do it without IV contrast in my practice. So CT thorax is your mandatory investigation for metastatic workup. What about a routine ultrasound of the abdomen, a bone scan, or an MRI of the brain? No. Unless the patient has specific symptoms pointing to those areas. These are not part of your routine metastatic workup for oral cancer. I see many of you answering in exam routinely as reflex. Sir, I will do ultrasound of the upper abdomen to look for liver metastasis. Liver metastases are very rare in head and neck cancer. Do not even look for metastasis in liver. Of course, you may do it to look for alcoholic liver disease if you think your patient needs, if he is a heavy drinker. But don't say you will do it to look for liver metastasis. Now let's talk about the elephant in the room, the PET-CT. This is a huge misconception out there right now. Since PET-CT is available in every city these days, I see people ordering a PET-CT for almost every new oral cancer patient because they think it is the ultimate all-in-one stop solution to evaluate primary tumors, cervical node and distant metastasis. Please stop doing this. Do not order a PET-CT to look for the primary tumor or to stage a clinically negative neck. Why? First of all, you remember that the meta-analysis by Leo et al. I showed you. It consistently showed that PET-CT is absolutely no better than high quality CT or MRI for detecting occult cervical nodes. Second, FDG is not cancer specific. You know what else lights up on a PET scan? So when do we actually order PET-CT? The indications are very selected. You only ask for a PET scan when your loco-regional imaging tells you that there is a high probability of distant metastasis. Based on our guidelines, you order it in these three specific scenarios only. First, number one, when you see multiple cervical nodes involved. Two, the disease has reached the lower neck nodes, level 4 or level 5. And number 3, you have a large, bulky single N3 node. In these specific cases, the risk of cancer having already escaped the neck to lung or other areas is high enough to justify the PET-CT. In these patients, the PET-CT has incredible value for picking up subtle extrathoracic metastasis that would change your entire treatment intent from curative to palliative. Do not order PET-CT based on T stage of primary tumor, even if it is T3 or T4. Trust me, you don't get any additional information beyond CT thorax. So here is the bottom line. Use your MRI or CT to stage the primary and neck. Use a CT thorax to check the lungs. Keep the PET-CT away until the nodal disease gives you a reason to suspect cancer has traveled further. So with this, we have completed everything you need to know about imaging for oral cancer. Look guys, I know this entire lecture of mine feels like a heavy radiology today. And for a lot of you, this might be the very first time you are really being pushed on these imaging details. But let me be very clear. I'm not trying to turn you into a radiologist. My goal here is to make you reasonably well-trained oncologist who can independently take decisions for your patient rather relying 100% on radiologist typed report. Think about it. You are already interpreting imaging every single day in your life. You just do it in indirect way. Every time you sit down and decide between surgery and RT, or debate a unilateral versus bilateral neck dissection, or when you are planning your elective versus definitive dose or volume, you are making those massive clinical decisions based on what the imaging says. So learning to read the scan yourself is not extra work. It is the exact same work you already do. But now the control is actually in your hand. And the best part, you don't need to memorize 50 different complex radiological concepts. Leave them for radiologists. I know talking all this all this feels incredibly heavy today, but I want you to trust me on this timeline. If you start doing this now, in just 2 weeks, it simply becomes pattern recognition. And in 3 months, you are going to look back and wonder why this ever felt so difficult. So for right now, please don't aim for master every single thing on the scans. Your only goal should be to consistently apply the exact same checklist to every single case that comes in your OPD. When it comes to staging oral cancer on imaging, remember, consistency beats intelligence every single time. The real work begins in the next set of videos, treatment of oral cancer. As you must have noticed, I made 6 videos on oral cancer before I even touched treatment part, because I feel it is the #1 cancer in our country and we all need to master management of oral cancer. And to learn management, we had to understand the fundamentals of oral cancer, including workup and imaging. Next videos are going to be very interesting and clinically very relevant. I will cover surgical, radiotherapy and medical oncology part in detail. Signing off, Parveen Elawat.